Good morning, everyone. Today, in our FRCS Viva preparation training, we are starting a new topic, male LUTS. This is one of the topic where lots of evidences could be brought in to the table, making the discussion very enriched and also very interesting. We are going to divide this topic into male LUTS evaluation and medical management, and second part will be various surgical options. As you know, in 2021 we have so many surgical options for BPH. Anish, floor is yours.
Thank you so much, and good morning, everyone. So you are in the BPH table. One of the GPs has referred a 62-year-old gentleman who has difficulty in passing urine, and he wakes up twice at night. So how are you going to proceed with this gentleman?
Yeah, I will see this patient in my dedicated LUTS clinic. On arrival, patient should have a urine stick. I've already sent the patient the frequency volume chart for 3 days to be filled in, and the IPSS as well. I will review the patient, take a history, concentrating on type of lower urinary tract symptoms, the voiding and the storage symptoms, and post-voiding symptom as well. I will ask also about any red flag symptoms like presence of hematuria, weight loss, bone pain, a new onset of neurological symptoms, or the presence of new onset bedwetting as well. I will ask about any associated symptoms like dysuria in the patient. I will ask about whether he had used any treatment previously for the prostate in the form of alpha blocker or 5-alpha reductase. I will ask after that to review the patient's medical history, asking about all other comorbidities and the use of medication, especially neurological disease which may affect the bladder function, and also the use of any medication like anticholinergic medication or other medication which may affect his LUTS, and I will check if he is using any anticoagulant. I will ask about the previous surgical history, about any urological manipulation or catheterization before, any surgery or radiotherapy previously. I will ask in his social history about smoking, drinking habits, any type of drink that he's using, like caffeinated drink or alcohol. I'll ask also about his baseline sexual status and the bowel function. I will check the impact of these symptoms in his social life and work. After that, I will also check if there is any risk factor for prostate cancer, like ethnicity or family history. After that, I will do a focused physical examination in the presence of chaperone with the patient consent. I will examine the patient generally, looking for his gait, for any feature of uremia or fluid overload in the form of lower limb edema. I will examine the patient abdomen, looking for any palpable kidney or palpable bladder. I will examine the genitalia, looking for any abnormality causing these symptoms like phimosis, meatal stenosis, any palpable nodule in the urethra which may suggest urethral stricture. I will complete the examination by doing a digital rectal examination, looking for the prostate size, symmetry, consistency, and the presence of any nodule. I will check the anal tone, and I will check the rectum if there is any loaded rectum which may indicate a constipation. And I will do a focused neurological examination if there is a suggestive symptom in the history.
Very good. You have covered almost everything of what is required in the initial part of the history. Well done.
Thank you.
For this gentleman, he is 62-year-old. The onset of symptoms was like 8 months ago. And the symptoms are on and off, but has been aggravated over the past 4 weeks. For the past 6 weeks. There are no red flags there is no significant medical history except for hypercholesterolemia. His sexual function is really good. He has got a stable partner. No current medications. Has tried tamsulosin, but he feels that it hasn't improved his symptoms. General examination fine. DRE, it feels like a benign feeling prostate, and roughly it is around 50 gram. There is no neurological abnormalities. You already said about the frequency volume chart and IPSS. What other investigations do you want in this patient for his management?
So for this patient, I will check his urine dipstick, looking for any protein, a blood glucose or feature of infection, which may be related to his symptoms. I will check his IPSS, which is a validated questionnaire, and give us an idea about the severity of symptoms. I will check his frequency volume chart, looking for the amount and type of fluid that he is drinking, and also for the amount of urine that he is passing, which give us an idea about his frequency, nocturia, and also about his functional bladder capacity. I will ask the patient usually to attend the clinic with a comfortably full bladder, so we can perform a flow rate on arrival. I will look at his flow rate, looking at the voided volume, the Qmax, and the pattern of the flow rate, and I will do a post-void bladder scan to confirm complete emptying. Since the patient is above 50 years of age, and he is presented with lower urinary tract symptoms, so this is an indication according to the NICE guideline to perform a PSA blood test. So I will counsel the patient about the pros and cons of PSA blood test, and I will perform one. And after that, I will check if the patient has any symptoms or signs suggestive of renal impairment. I will arrange for a blood test for kidney function as well.
So when will you suspect the patient has got a renal impairment? What are the clinical signs that make you think that this patient might have renal impairment?
So if the patient already known to have a chronic kidney disease or disease associated with renal deterioration like diabetes, then I will do that. And also on examination, if the patient have a feature of uremia like a fluid overload, acidotic breathing, bilateral lower limb edema, then I will consider that. If the patient is also known to have a stone disease, I may consider doing the blood test. And if there's any feature suggestive of high pressure chronic urinary retention, then I will order the blood test as well.
Well done, well done. What are the indications? I mean, normally, will you do a cystoscopy in a fit and well gentleman with only the presenting symptoms of urinary symptom? I mean, the only presenting features of moderate, bothersome lower urinary tract symptoms? Will you routinely do a cystoscopy?
No, I will not perform a cystoscopy routinely. The indication for cystoscopy, if the patient presented with hematuria, recurrent UTI, sterile pyuria, profound symptoms, pain, or if there is a suspicion from the history or examination that the patient may have a urethral stricture, then I will do a cystoscopy for the patient.
All right. You mentioned about International Prostate Symptom Score, IPSS. Can you tell me more about IPSS and how does it help you in your management plan?
IPSS is a validated questionnaire to evaluate the patient's symptoms. It was proposed by the American Urological Association in 1992. It composed of 7 questions and 1 question for quality of life. The questions are scored from 0 to 5, so the total should be from 0 up to 35. It asks about patient symptoms over the last month, 4 of the question about voiding, 3 of them about storage. And according to the total number, we can estimate the severity of symptoms. So from 0 to 7, mild symptom, from 8 to 19, moderate symptoms, and from 20 to 35, severe symptoms. I am aware of some of the limitation of the IPSS, including it is subjective. It doesn't contain a question about incontinence, and there is no separate bladder score for each question. And as we know, some of the symptoms are causing more bladder than others.
All right. Well done. What is the difference between frequency volume chart and a bladder diary?
So the frequency volume chart is mainly looking at the number of voiding and the amount of voiding. While in the bladder diary, we include everything the patient drink and everything the patient pass. So to tell us about the amount that the patient drinking and the type of the fluid that he's drinking, and also the frequency of urination and the volume of the urine passed. And usually we need to do the bladder diary for 3 days.
Okay, well done. Will you consider, or what are the indications to do urodynamics in a patient presenting with lower urinary tract symptoms?
So a urodynamic is an invasive procedure. So I will consider urodynamic for patients who are less than 50 years of age or more than 80 years of age, patients who had a previous bladder outlet surgery which failed to improve his symptoms, patient known to have some neurological disease, and also in patient who unable repeatedly to void more than 150 ml to have an appropriate flow rate, and also in patient with a significant post-body residue of more than 300 ml. This is in accordance with the EAU guidelines.
Is it necessary to do urodynamics in all patients? I mean, you said about the indications, but the question is whether it will improve the outcome of the surgery if you practice doing urodynamics in all patients who is about to undergo bladder outlet obstruction surgery.
So I will consider urodynamic only if this is going to change my treatment decision. And I am aware of a study done in Bristol, the upstream study, where they have done a urodynamic study for all the patients before considering prostate surgery. And actually there was no strong evidence to support the protein use of urodynamic before prostate surgery. And in most of the time, it doesn't affect the treatment decision or the surgical outcome following the procedure.
All right. When you are looking on a urodynamic chart, what is the indication that says that this patient is going to get benefited from surgery? Or what are the parameters that would suggest that a certain patient will be maximally benefited from having the bladder outlet obstruction surgery?
So I will look, according to the ICS nomograms, we have the Abraham-Griffiths number, which we can get from the urodynamic study. It is the bladder outlet obstruction index, which can be calculated by measuring the PHYTOTHERAPY at Qmax minus 2 Qmax, and then we will look at the result. If it is more than 40, this indicates bladder outlet obstruction. If it is less than 20, this is not obstructive, and 20 to 40 is equivocal. And we know from previous studies that patients who have a proven bladder outlet obstruction, they will have a good outcome following prostate surgery with 90% improvement of symptoms, compared to 60% improvement of symptoms in patients without a proven bladder outlet obstruction.
Well done. What is bladder contractility index?
So the bladder contractility index is another parameter which we can calculate it from the urodynamic information. It's calculated by measuring the P detrusal at Qmax plus 5 Qmax. And if the result is less than 1%, if the result is less than 100, this indicates a weak bladder muscle, 100 to 150 equivocal, and more than 150 indicate a good contraction.
Well done, very good. So just going into the embryology, where does the prostate develops from?
So the prostate will develop between the 10th and 16th week of gestation by outgrowing of pods into the posterior part of the urogenital sinus. The prostate has two embryological origins. So the central zone of the prostate arises from the mesonephric duct under the effect of testosterone, while the rest of the prostate is arised from the urogenital sinus under the effect of sorry.
Yeah. So there are two.
Dihydrotestosterone. Yeah.
All right. And what are the zones of the McNeil's prostatic anatomy?
So McNeil have divided the prostate into a few zones, including the peripheral zone, which represents 65% of the prostate, the central zone, which represents 25%, and transition zone, which represents 10%, and a small anterior zone.
Okay. And in the exam, you will be asked to draw the Hall's rings. What are the components of Hall's rings?
So these are three intermingled rings, which is the benign prostatic hyperplasia, bladder outlet obstruction, and LUTS.
Okay. And what is the importance of Hall's ring, or what is the inference of Hall's rings?
The importance is that it indicates that the symptoms are quite a mix between the three. So LUTS may happen due to prostatic enlargement or just benign prostatic hyperplasia. It indicates that all the three cases are quite intermingled together.
And the patient who has all the three features will be maximally benefited from the surgery.
Okay.
All right. How prevalent is BPH in the community?
Yeah, so we have some evidence from the Olmsted County study, which was performed in the 1992. They randomly collect 2,100 men between the age of 40 to 80, and they assess the presence of LUTS in these patients, and they found that 26% of men between the age of 40 to 49, they have moderate to severe LUTS, and 46% of men between the age of 70 to 79, they have moderate to severe LUTS. So this study gives us an idea about the prevalence of LUTS in the community.
All right. Do you know about any UK study saying about the prevalence of BPH?
I'm not quite sure, but I think the control arm of some of the other medication study, like the PLESS and MTOPS, has looked into that as well. Exactly.
And there is a Garaway longitudinal study, which is a UK-based study. The inferences are almost similar to the Olmsted County study and also the placebo arm of the Proscar study.
Okay, thank you.
All right. So what is the natural history of BPH? The question is whether you have to treat all BPH or what happens if you just observe men with BPH.
Yeah, so most of the BPH will progress clinically, and we have evidence again from the Olmsted County study that there is a deterioration on the IPSS by 0.2 percent point each year, and also there is a reduction in the peak in the median peak flow rate by 2% each year. and there is an annual incidence of acute urinary retention of about 1% in the men between the age of 40 to 49, compared to 9% in men at the age of 70 to 79.
Well done. So when you see a patient in the outpatients with bothersome urinary symptoms and features of BPH, what are the predictors in the history and investigation that will help you to say that this patient is going in for a BPH progression? Is there any study which gives us idea of what are the predictors of BPH progression?
Yeah, so the indicator for the clinical progression of LUTS mainly derived from the Olmsted County study and the placebo arm of the medication study like MTOPS and the PLESS. The main risk factor include age above 70, prostate volume more than 30 gram, PSA more than 1.4, moderate to severe symptoms more than 7 in the IPSS, peak flow rate less than 12 ml per second. So these are the main clinical indicators. The other indicators including lack of initial response to medical treatment as well, which indicate high likelihood of progression.
Okay. So our patient, he says that he gives the IPSS as 12+3. On further questioning, he admits that he hasn't taken tamsulosin much because he always wanted to, because he's relatively young, 62. He doesn't want to start any tablets for him. So he has taken only 4 or 5 tablets of tamsulosin and stopped it. So what are the management options for a patient with a IPSS score of 12+3 with the lower urinary tract symptoms?
So for this patient, I will see the patient in the clinic and I will understand why he stopped the tamsulosin. Is it because of the side effects? I will counsel him about possible side effect of the medication. If it is due to the lack of efficacy, I would suggest that he need to use the medication maybe for a longer time to have the maximum benefit. If the patient is not happy to try tamsulosin, I can try with him another member of the alpha blocker family, or to start him on finasteride treatment.
Okay. What are the lifestyle changes that you would advise for a patient with lower urinary tract symptoms?
Yeah, so this is the first step in treatment of patients with LUTS. I will start by reassurance and explaining about the nature of the disease. And then after that, I will ask the patient to modify his fluid intake. So he need to avoid any caffeinated drink like tea, coffee, fizzy drink. He need to reduce his alcohol intake as well. Avoid drinking for the last 2 hours before going to bed if he is having significant nocturia, and also to empty his bladder just before he go to bed. I will ask the patient also to do double voiding and urethral milking gently when he finished, which will help to improve his post-micturition symptoms. I will ask the patient to avoid any constipation. I will review his medication and stop some of the medication which may affect his flow. And ask the patient also to do some pelvic floor exercise, which may help to improve his control. So these are the main conservative measures.
Okay. You can complete this. That's a really comprehensive answer. As you're aware, there is a BOWS information leaflet on. There are actually 2 information leaflets on the LUTS in men and also the management of LUTS in men, which was published 2 months ago in July. So if you can tell that you will give the BOWS information leaflet on the management of lower urinary tract symptoms in men. So it will be a comprehensive document covering all these things. And it will give you a good impression during the exam.
Yeah, definitely.
What about phytotherapy?
So phytotherapy is not recommended by all the guidelines, including NICE and European guideline. I know about the phytotherapy, certain, I just forget the name.
So saw palmetto?
So palmetto. So palmetto is one of the well-studied phytotherapy. It acts by multiple mechanisms, including anti-inflammatory mechanism, and also it has some 5-alpha reductase inhibition activity. Therefore, prolonged use of saw palmetto may affect the PSA in a similar way to finasteride. And I'm aware about something called seronereplins, which is a new form of herbal therapy. And there are some studies showing that a combination of tamsulosin and seronereplins will give the patient some symptomatic improvement. However, in my practice, I don't recommend any phytotherapy in accordance with the NICE guideline.
All right. So in between, you mentioned that if the patient is not happy to start tamsulosin, you will prescribe him finasteride or any 5-alpha reductase inhibitor. According to the NICE guidelines, what are the indications to start a 5-alpha reductase inhibitor for a patient with LUTS?
So the main indication is a patient with a prostate volume more than 30 grams, patient with moderate to severe symptoms, and patient who have a risk of clinical progression due to the presence of indicator of clinical progression. It can be given alone or in combination with tamsulosin.
Is there any PSA cutoff that's mentioned in NICE guidelines?
I'm not aware of the PSA cutoff, but any patient who about to be started on finasteride, I will do a dish rectal examination and I will have a baseline PSA because after we start the finasteride, there will be some masking of the PSA, and the finasteride known to halve the prostate by 6 months of use.
Okay, so the guidelines also state that apart from the other things that you have mentioned correctly, the prostate more than 30, patients at high risk of progression and with moderate to severe LUTS, and it also mentions PSA more than 1.4.
Yes, which is one of the clinical indicator. Yeah.
When would you consider giving anticholinergic to a patient with LUTS?
It's mainly for a patient who is having a persistent storage urinary symptoms, which fail to be controlled with the conservative treatment and with the use of tamsulosin. And then for this patient, I will add anticholinergic medication or beta-3 agonist to control these symptoms.
So you counsel the patient well for the alpha blocker, so he's clear now that he has to try on restarting the alpha blockers. So when you are counseling him, what do you tell about the adverse effects of alpha blockers? Because you are going to prescribe him tamsulosin. So what will you advise him regarding the adverse effects?
So the main side effect of alpha blocker include asthenia, dizziness, postural hypotension, nasal congestion, and lack of ejaculation due to lack of emission of the semen. These are the main things. I will inform the patient that usually tamsulosin will start acting within short time, usually within 24 hours. And he need to take the tablet daily to improve his symptoms.
Okay. He's asking whether it will affect his libido and erectile function.
So no, there is no evidence that alpha blocker will affect the libido, and also it doesn't affect the erectile function. However, when the patient's symptoms improved with alpha blocker, some of the patients, they notice also improvement in their sexual parameters. And as we know, alpha blocker may induce some vasodilatation on the cavernosal muscle. So most of the study showed some beneficial impact of alpha blocker on sexual function.
Okay, well done. Will the alpha blockers help to reduce the risk of acute urine retention?
No, actually, most of the studies show that the alpha blocker will improve the reduce the IPSS by 30 to 40% of the patient. It will improve the flow rate, maximum flow rate in about 15 to 25% of patients, but there is no evidence that it will reduce the risk of acute urine retention on the long term.
Well done. And because you counsel him for the finasteride as well, because his prostate volume was 50 grams. How does finasteride act?
So finasteride is a 5-alpha reductase inhibitor. It inhibits type 2 5-alpha reductase, which is present in the prostate, and by this it stops the conversion of testosterone into dihydrotestosterone, which is the active form, and this will cause a reduction in the size, especially of the glandular element of the prostate, and by 6 months the prostate size will be reduced by about 30%, and this will help to improve the symptoms, and also on the long term it reduces the rate of progression of LUTS, it reduces the incidence of acute urinary retention, reduce the need for surgery, and we have evidence for that from the PLESS study.
All right. What's the difference between dutasteride and finasteride in the mechanism of action?
So dutasteride inhibits both type 1 and type 2 5-alpha reductase enzyme. Type 2 usually present in the prostate, type 1 present in other tissue like skin and liver. So both of them will cause a significant reduction in the level of dihydrotestosterone. However, biochemically, dutasteride is more effective. However, there is no evidence that it is clinically more effective than finasteride. And if we look at the cost of two medication, it is in favor of finasteride versus dutasteride.
Well done. What are the side effects associated with 5-alpha reductase inhibitors?
So the main side effects are sexual. So a patient will notice a loss of libido and erectile dysfunction. And in about 6% of the patient, they may have some breast enlargement and tenderness. And very occasionally, it may cause some rash. Obviously, if the patient is young and is still willing to have children, he should avoid any pregnancy, and the couple should use some contraceptive measure if he's using finasteride.
Okay. Can you already told me about the evidence for finasteride. Can you give me more, or can you elaborate more on the PLESS study? What did the PLESS study show?
So the PLESS study is the Proscar long-term safety and efficacy study. It includes about 160 men with a follow-up for about 4 years. They give them finasteride versus placebo, and they noticed that the patient who had a finasteride, they have a reduction in the rate of acute urinary retention by 55%, and also reduction in the need for surgery by 55%. Well
done. So you are planning to combine the tamsulosin and finasteride for this patient. So what is a study that help us to realize that a combination is possible and the combination is better than giving either alone?
So we have two evidences from the MTOPS and from COMBAT study. The MTOPS study include about 3,000 patients with follow-up for 4.5 years, and the primary outcome was overall clinical progression. Inclusion criteria, the male should be more than 50 years, IPSS score of 8 to 30, and the Qmax between 5 to 15 mil per second. And then there is the combination arm, the monotherapy arm, and the placebo arm. And this showed that the combination treatment reduced the incidence of acute urinary retention and the need for surgery by 81% and 67% respectively, compared to finasteride, which reduced it by around 65%. Also, the clinical progression, the combined treatment reduced clinical progression by 66%, compared to about 40% for each of doxazocin and finasteride. The other study is the combat study, in which dutasteride and tamsulosin were used. Again, follow-up for 4 years. Similar inclusion criteria, but they add also prostate volume more than 30 cc and PSA 1.5 to 10, around 4,800 patients. And it showed that the combination therapy reduced the rate of acute urinary retention by 66%, a similar reduction rate by dutasteride. However, the reduction rate by tamsulosin was only 20%. It also reduced the progression in the combination therapy by 44% versus 30% in tamsulosin. So this is the main evidence for the combination therapy.
Well done, well done. You said that you will add anticholinergics anticholinergics if the patient has got storage urinary symptoms. What is the main evidence of that study comes from, or the earliest evidence of that which study showed that there can be improvement in the urinary symptoms, especially storage symptoms, when we start a patient on an anticholinergic?
Yeah, the evidence came from Neptune 1 and Neptune 2 study. So in Neptune 1, there was about 1,300 patients with mixed lower urinary tract symptoms with flow rate between 5 to 15 ml per second. And the inclusion criteria include also post-void residue less than 150 ml. So the patients were divided into a placebo group and the other group having only tamsulosin, and the other group, they having a combination of 6 milligram of sulfonylurea with tamsulosin or 9 milligram of sulfonylurea with tamsulosin. They follow the patient initially for 12 weeks in the Neptune 1, and then in Neptune 2, the follow-up extended up to 1 year. And they found a significant improvement in IPSS on those patients, especially the storage-related IPSS. And it shows also the safety of anticholinergic medication in these patients with incidence of acute urinary retention of about 1.1%, which is similar to the general population. Therefore, it was recommended that it is safe to use anticholinergic medication in patients with LUTS, providing that their flow is more than 5 ml per second at least, and the post-void residue is less than 150 to 200 ml.
Well done, yeah. Do you use phosphodiesterase 5 inhibitors in your practice for patients coming with LUTS?
Not for all the patient. If the patient is having a significant erectile dysfunction with lower urinary tract symptoms, then I can use PDE5 inhibitors in combination with tamsulosin, because the evidence from the study showed that PDE5 inhibitors monotherapy, it helped to improve the IPSS, but it's not improving the flow rate, while meta-analysis of a few studies assessing the combination of tamsulosin with PDE5 inhibitors showed improvement in the IPSS and the flow rate as well. I will warn the patient that this may increase the potential of hypotension. Therefore, I would recommend for the patient to use them separately. So one of them in the morning and the other in the night.
Okay, well done. So your patient is very happy with all the explanation. So you are sending him, and he agrees to have to start the tamsulosin. So how would you follow up this patient?
So if I start the patient on tamsulosin, I will see him in the clinic after 6 weeks, if it is possible. I will reassess the symptom again. I will ask the patient to fill the IPSS and the bladder diary again. And if there's a significant reduction in his flow rate, initially I will repeat the flow rate and the bladder scan. After that, if the patient is happy with the medication and it showed improvement of his symptoms, I will follow the patient in the clinic every 3 to 6 months.
Well done. So your patient is stable now with no bothersome urinary symptoms. Coming to the complications of benign prostatic enlargement, can you tell me some of the complications that we can expect as this patient moves on?
Yeah, so as the patients move on, the possible complication is recurrent urinary tract infection, recurrent hematuria due to prostatic enlargement, significant postword residue which is associated with back pressure on the kidney and renal deterioration, development of a bladder stone and bladder diverticulum, and patient may progress into acute or chronic urinary retention. And with time, the response to medical treatment will start to fade away, and the patient may progress into either more severe symptoms which require surgery, or he will fulminate in acute urinary retention, and then surgery will be indicated as well.
All right. So, what is acute? I mean, what is the definition of acute urinary retention?
So the acute urinary retention is a painful inability to pass urine. The patient presented acutely, while in chronic urinary retention, a patient may be able to pass urine. However, he is having significant post-void residue, and most of the time it is painless or associated with mild discomfort.
Okay. For the treatment and outcome purposes, what is the classification of acute urinary retention?
So we can classify it into high pressure, the acute one.
Sorry, the acute one, yeah. Is the difference between spontaneous AUR and precipitated?
Yeah. So we have either the acute urinary retention, maybe a spontaneous one without obvious precipitating factor, or maybe a precipitated one, which is maybe precipitated by some urinary tract infection, constipation, use of certain medication, or the patient maybe just forget to take his tamsulosin tablet. Usually the prognosis of the spontaneous, usually the prognosis of the precipitated one is better than the spontaneous one.
All right. So not this patient. If another patient comes to A&E with acute urinary retention, and the A&E team is calling you, they managed to put a catheter, it is draining clear urine, his electrolytes are normal, there is no post-obstructive diuresis. So what will be your advice to the A&E team for that patient?
So for this patient, I want to take a history to see about his LUTS symptom before the retention, whether he's using any medication or not, if there is any precipitating factor like constipation, or infection, then this need to be treated. If the patient, I want also to examine the patient, check his digital rectal examination to make sure that there is no possibility of prostate cancer. If the residual amount was less than a liter, a patient clinically well, and he have a recent kidney function, there is no need for blood. But if the residual amount was significant, more than 1 liter, patient showing feature of volume overload, I will ask for a blood test to check the kidney function as well. Providing everything is fine, I will make sure that the patient is already on tamsulosin, or if not, then I will start him on tamsulosin treatment, explain the possible side effect, and then I will arrange for him to have a trial without a catheter within 5 to 7 days.
Okay. What is the evidence for the success of The success of alpha blockers in the trial without catheter?
So this comes from the Alpha UR study, which divided the patient presented with acute urinary retention, and the bladder ultrasound showed a residual volume between 500 up to 1500 mil. And included in the study, divided into placebo and the other arm given alphazocin 10 milligram. And then the patient was TWOC'd, and it showed that TWOC was successful in 66% in the alphazocin arm compared to 48% in the placebo. And they found that alphazocin doubled the likelihood of having a successful trial without a catheter, even in patient older than 65 years and in patient with a residual volume of more than 1 liter. However, this benefit has been noticed for the first 6 months only.
Okay, well done. And if the patient fails a first trial without catheter, will you give him a second trial, or will you counsel him for surgery?
In my practice, I will offer the patient a second trial without a catheter.
What's the evidence for that?
I'm not sure, but I think the evidence came from the Alpha UR study as well.
Yeah, so there was it's more like a survey by Fitzpatrick et al. This is one of the papers that was asked during my Viva session. So in that one, almost 6,000 patients were evaluated. And that's a study that helped us to say that we can trial without catheter in 3 days' time. And it also showed that there is no benefit of keeping the catheter for more than 3 days, because it will not influence the outcome of TWOC success. But if you keep the catheter for more than 3 days, there is a associated increase in morbidity, and there is a risk of prolonged hospitalization. So the ideal time for a trial without catheter after starting alphazocin, the earliest is 3 days. And it also confirmed the ALPHA study, finding that the alpha blocker doubled the chance of success of TWOC. And the main thing was that if the TWOC fails, we can consider for a repeat TWOC. The success rate of success rate of initial TWOC is around 61%, and the success rate of second TWOC is around 30%.
Okay.
We will put that paper in the YouTube description. So it was published in the BJUI. So it's important to read that paper as well. ALPHA study, you did really well. You went through all the real points of all the studies. I'm happy with all the numbers. Just this one, because this is more like a comprehensive study, and that confirmed the findings of ALPHA study.
Okay, thank you.
Yeah, and so what are the indications for surgery in general for patients with benign prostatic enlargement?
So the main indication is failure of medical treatment to control the patient's symptoms or intolerance to medical therapy, refractory acute urinary retention, chronic urinary retention, deterioration of renal function, recurrent UTI, recurrent gross hematuria due to prostatic enlargement, development of a bladder stone, or the patient So these are the main indication for surgery.
Well done, well done. I think we can conclude the medical treatment part of BPH. Yeah, I thoroughly enjoyed this session.
Thank you very much.
Amazing, and you were really good at the numbers regarding the studies, and mainly what I felt is rather than just saying the numbers, you know what those studies were representing and what were the outcome of the studies that help us to improve our practice. That was there in your presentation. That was amazing, really brilliant. I enjoyed all the every minute of last 1 hour.
Thank you very much.
That's very nice, guys. It's again a wonderful in detail discussion. as I usually say, benign prostate and malignant prostate are the two tables where you need to bring in lot of evidences, and the floor is really changing every year. Thank you very much. I will try to incorporate all the evidences discussed in the YouTube channel so that it will be a very good source to refer back and also to revise. Thank you very much. Have a nice rest of the day.
Yeah, thank you very much for both of you. Thank you. Have a nice weekend.